Diane, I'm here.
Good morning, Diane. Let me give you the presenter role.
Thanks. How are you today, Kim?
I'm good. How are you?
Been a busy morning already.
I hear ya.
Ay. All right, there we go. Okay, look okay?
Looks perfect. Got a couple
Great.
minutes. You'll hear me come on at 10:30 your time.
Great, thanks.
Great. Okay, it looks like it's 9:30 my time. Thank you everyone for joining us today for this webinar. Just a couple quick things before we get started. Feel free to send in any questions that you have via the chat function throughout the webinar. We'll try to get those answered at the end. And also, certificates will be available hopefully tomorrow, if not on Monday, for all the attendees that are in the U.S. Diane, if you want to go ahead and get started, go right ahead.
Excellent. Thank you, Kim, and thank you for everyone around the world who has joined us. I think that Kim had mentioned that there are well over 400 registrants, so that's very exciting. I'm very pleased to be offering the first of Medila's webinar series related to COVID. I'm certainly disappointed that I did not get to be with everyone in Portugal in March. So we're going to think about this pandemic as an opportunity to really elevate the critical role of human milk and breastfeeding as life-saving medical interventions. I do have about 80 slides to go through, but I think I'll be able to do that and leave us a few minutes of time at the end to open it up to questions. I am going to give just a little background about myself in case we have never met or you have not had heard me speak ever. So I have 3 degrees from the University of Pennsylvania, a bachelor's, master's, and PhD, all from the University of Pennsylvania. This is a picture of me when I graduated from my baccalaureate degree. I had learned nothing about breastfeeding in my program. We never had any lecture content on it. And where I did my clinical experience, I did not ever see a breastfeeding woman at all. I myself was not breastfed as a child, so I have had zero exposure to breastfeeding in my life, and went to work at a very busy birth hospital when I graduated, and found it to be very stressful not having that knowledge. So I have spent my career really working on strategic methods to make sure that nurses in particular have the evidence to be able to provide research-based lactation support and care. While I was working full-time as a staff nurse and in school for my master's degree, I was introduced to research on human milk and breastfeeding and wrote my first research grant while I was a doctoral student, and that was funded the year I received my PhD. So this is actually a picture of myself in my cap and gown with my husband, and I finished my PhD, got funded, and was appointed to be an assistant professor at the University of Pennsylvania. Now, at that time, we thought if we have an National Institute of Health grant about human milk and breastfeeding, we better darn well teach our students something about it. So in 1995, Nursing 361 was born. It is the first ever undergraduate course on human milk and lactation for nursing students. And this course has been focused as a best practice in the United States by the Centers for Disease Control and Prevention. Also, after becoming faculty and after our NIH grant finished, I was recruited to Children's Hospital of Philadelphia to start a lactation program. And I knew very clearly, based on the research I had been doing while I was getting my PhD and the grant that we had funded right after my PhD, that trying to apply the Baby-Friendly Hospital Initiative to sick infants really is not effective. It does not address the needs of critically ill newborns. And so that's when I just developed my 10-step model, and we have been using this at Children's Hospital of Philadelphia now for well over 15 years. Our pumping initiation rates are quite high. They are approximately 99%, and the majority of our babies do go home on human milk and breastfeeding. And I think this is really important to note because human milk at discharge is considered a quality metric for our hospitals. So now I'm going to jump into the COVID content. And I'm first going to start by sharing a Philadelphia television story that aired during the pandemic last month. The mother was on TV with her older children and her partner. She said that she had breastfed her older children. She had twins in a local neonatal intensive care unit, and she very much desired to breastfeed her twins. However, at this particular hospital, they were allowing no parental visitation at all. So no parents were allowed to go into the hospital to see their children. And the mother, her only thing that she could do was drop off milk to the curbside. And when I watched this news story, I will say I cried. I mean, it really disturbed me and made me very sad. To think that this mother was not able to see her children, nor was she going to receive any type of support for breastfeeding her children before they were discharged. So, you know, if you think about that, what is that in terms of both the mother and child's human rights, and where, where is the opportunity for shared decision-making between healthcare providers and parents? So I'm going to briefly go through some international guidance. I have recently been elected to the Executive Committee of the International Society for Research in Human Milk and Lactation, and I have actually recommended to all the healthcare professionals I've spoke to use their website kind of as a curation of information about the pandemic. They provide not only guidance for collecting human milk for analysis, but they also provide evidence summary and resources. And those resources have been translated into multiple different languages. There is also a curated Excel database of current literature. So from the beginning, both the UNICEF and the World Health Organization have endorsed and supported early exclusive breastfeeding as well as skin-to-skin contact. And so I think it's really important to start both with those UNICEF and those World Health Organization guidelines that really emphasize that mothers and babies should be kept together. They should be skin-to-skin. they should be rooming in, they should be breastfeeding. So even if the mother is COVID positive, we want to support them with breastfeeding. They just need to practice appropriate respiratory hygiene and wear a mask, obviously very good hand washing, and routinely cleaning and disinfecting surfaces. The World Health Organization also furthermore really emphasizes the protection of milk supply during this pandemic. So either through expression if the mother is too unwell to directly breastfeed, through considering relactation if the mother had stopped, or the use of donor milk if mother's own milk was not available. So strong endorsement of protecting maternal milk supply. The World Health Organization also has a fantastic frequently asked question sheet for healthcare workers. And I think what is most useful is their decision tree. And I really like it because it does really clearly take you through guidance in terms of the mother who is suspected a person under investigation or a PUI or confirmed, encouraging that direct breastfeeding, encouraging express milk if the mom's not able, access to donor milk bank, and if there's no donor milk bank, if wet nursing is culturally acceptable and a safe wet nurse could be identified, the facilitation of that. So they really, really, in all counts, are emphasizing the importance of human milk and breastfeeding as life-saving medical interventions. This has been a question that has come up quite a bit for me, and this is in terms of breast hygiene. Some hospitals are making mothers wipe their breasts before every single milk expression or breastfeeding session, and that is not appropriate because if we do this, we disrupt the microbiota of the mother and baby. So if you were a healthcare provider working with COVID-positive patients, or you were a COVID-positive mother yourself, you would only need to wash the breast or the chest if there was direct coughing onto the chest wall. It is not necessary to wash the breast before every breastfeeding or milk expression. Canada provides some wonderful international guidance as well, and what I think is particularly helpful in their guidance is they talk about the visitor situation, and they really address that it is critical that people practice social distancing, even though it is a time of great joy and families and friends would like to see each other. This is not the time to do so, and that we should be observing social distancing. The UK has just recently in May updated their support. I just double checked it again. And I think this is also very nice where they talk about when mothers are partially breastfeeding, they can be encouraged to maximize the amount of milk they give or attempt to choose to full breastfeeding. I also think it's really important to note that they do say that if they're considering stopping, it's worthwhile to have a conversation about the importance of continuing breastfeeding during this pandemic. In Italy, their recommendations have always supported direct breastfeeding and early skin-to-skin contact, and in addition, they also have called for the role of pasteurized donor human milk in the absence of mom's own milk. China has been the only country to recommend not breastfeeding. So in China, mothers with confirmed or suspected COVID were recommended to stop breastfeeding. There is, however, a lack of evidence to support this practice. And in this particular case study, the report analyzes a case of a mother who were diagnosed with COVID positive. And what they found was the presence of antibodies were in the milk. So the Centers for Disease Control and Prevention in the U.S. have recommended breastfeeding. Again, their recommendations are not as strong as UNICEF or the World Health Organization because they use language such as if you have COVID and choose to breastfeed, right? So they're now talking about maternal choice or parental choice. They focus on doing the face covering and the hand washing. And of course, focusing, if the mother is on pumping, on appropriate pump hygiene, as well as making sure the mother has either a dedicated pump or that the pump would be cleaned appropriately in between use. The Academy of Breastfeeding Medicine International Organization does recommend that it is the mother's choice to breastfeed, and I, in particular, like their guidance on in-home management, which states that COVID-19 individuals should remain separate on home isolation from other family members, friends, and neighbors, including the infant, except for direct breastfeeding, so supporting the COVID-positive mom to breastfeed at home. The American Academy of Pediatrics has been the professional organization that has recommended separation, and this is to minimize the risk of postnatal infant infection. So I think it's very, very critical to remember that if a hospital is choosing to separate mothers and infants, then we have to focus on the critical window of opportunity to protect milk supply. And I will be giving a future webinar for Medela on July 9th that is really going to focus on that critical window of opportunity. And I have heard from my colleagues, both in the United States and in the world, that there are many hospitals are separating mothers and babies who are either PUIs or COVID positive. And if this is done without the protection of maternal milk supply, we are going to set that family up for not being able to meet their personal breastfeeding goals once they go home. So Dr. Allison Stubbe, who is the current president of the Academy of Breastfeeding Medicine, published a commentary about that practice of separation and really the importance of not creating harm or not doing harm. We know from the China experience that separation of the mothers and infants may not prevent infection. We know that interrupting skin to skin disrupts the newborn physiology. We also know that separation stresses the mother, and I would also argue stresses the infant. It disrupts that microbiota. And if hospitals are separating mothers and children, they are also going to have to spend more money because they are going to have to invest in more personnel resources, more people, because you need someone to take care of the mother and someone else to take care of the baby. And that means you're going to expend more money and use more personal protective equipment. So it's been in the media quite a bit in the U.S., and they even made the New York Times. And, you know, parents are very confused. They're very concerned. They are worried about if their child can get COVID through breastfeeding. And what I think is really critical to remember is that other than China, okay, every organization globally has really emphasized that importance of human milk, even if separation is recommended. So what can we do as healthcare providers across the globe? I really know that in the U.S. and around the world, the current practice paradigm isn't working to make sure that all families can meet their personal goals. We have much work to do to ensure equal access to services. We have much work to do to ensure that all families have equal evidence-based lactation information. The rates in both the United States and worldwide are suboptimal. Globally, only 41% of infants are getting exclusive human milk for the first 6 months. And in some countries, those rates are well under 10%. In the United States, even though we have more mothers who start breastfeeding or providing milk, still less than a quarter of our infants receive exclusive human milk for the first 6 months. We have tremendous health disparities in the U.S. and around the world related to race, related to ethnic background, related to level of income, related to return to work status. So we can use this pandemic as an opportunity to really elevate the critical role of protecting and elevating the importance of human milk and breastfeeding. Families who do not choose the provision of human milk or breastfeeding may not have the resources to purchase infant formula. Because of the pandemic, people have lost their jobs, their income. On shelves in stores, you may not even be able to find infant formula. And we have found here in the United States that stores are even doing price gouging and tripling or increasing the cost of infant formula 3 times as much as baseline price. And so we have to make sure we're doing a better job before people ever deliver to make sure they're making informed decisions. Our United States Breastfeeding Committee has a COVID response team, which I am part of, and they have been emphasizing across the United States the importance of protecting breastfeeding in an emergency, including COVID-19. When a family chooses breastfeeding, we don't have to worry about access to infant formula or foods. And this particular slide I like to use as a great example because this is from the beginning of the pandemic back in early March in the United States. And this is one of my colleagues who allows me to share her experience. And her mother was texting her, and she was saying that she was worried about businesses closing, people having to work from home. She was worried about her grandbaby's daycare center being closed on short notice. And then finally, she asked her daughter, "Do you have enough food for my grandchild?" And the mother pointed to her breast and said, "Of course, Mom, I'm breastfeeding. I have plenty of milk. I have plenty of food for my baby." this is not something I have to worry about. And this picture is a picture of her daughter who she sent me. This was on Easter Sunday in the U.S., and she said, you don't have to worry about this baby starving. And if you can see the nice rolls of fat on that exclusively breastfed baby. So we really have to have families have messaging before they deliver that if you make that choice to provide milk to your baby, you're not going to have that added burden or stress of being worried about finding infant formula. So we're going to really spend the rest of the seminar now focusing how we can help our families understand the importance of human milk and breastfeeding as life-saving medical interventions. With this context, we really want to help families understand that they have an important role in their child's care, and that families, every family, should have the opportunity to engage in shared decision-making with their healthcare provider, okay? A healthcare provider should not just be telling a family what to do, but they should be engaging that family to understand their experiences and their values and their preferences to make the best decision for their family. So the Agency for Healthcare Research and Quality in the United States has some great curriculum and training on the SHARE approach, if this is something you are not familiar with. In the SHARE approach, you are going to seek your family's participation. You're going to help the family explore and compare treatment options. You're going to ask your family their values and preferences. You're going to come to a decision with your family, and then you're going to evaluate that decision. And you can see here when I'm speaking about breastfeeding, I am talking about the family, just not a patient, because a person who lactates does not do that in isolation, all right? So involvement of the entire family is critical. We need to change the current prenatal care paradigm around the world. Every single family we meet should be given information about the science of human milk. And human milk and breastfeeding should be discussed at every single point of contact in the prenatal time period. We need to provide families with appropriate anticipatory prenatal guidance. We need to teach them the science of human milk and the physiology of lactation. And we need to make them aware, if they have any risk factors, how to mitigate those. And I will be speaking more about that on July 9th. We also really need to talk to the families prior to delivery and help them understand that breastfeeding will take time and effort and commitment. It can be hard work. So we have a manuscript under review right now of a case series of mothers who we have interviewed during this pandemic. And the pandemic has changed childbirth for all families, not just for those who are COVID positive or a PUI. And all of the families we interviewed expressed common concerns about giving birth and breastfeeding during the pandemic. Stella stated that she had low expectations for her hospital experience. All mothers reported reaching out to friends instead of healthcare providers, in part due due to the pandemic. Ruth, in particular, stated, being a new mom is not as important as a healthcare provider taking care of sick COVID-19 patients. So clearly, there's an opportunity for us to do better for our families. So the model that I developed back when I finished my PhD was originally developed for mothers who have infants who are separated from them, not just preterm infants, but any infant who could be separated at birth. So during this current pandemic, this model actually has great applicability because we are seeing that families are getting separated from their newborn. So we really can use the steps of this model during the current pandemic. For today, the only part that I will be focusing on for the rest of the presentation is regarding informed decision-making. We do know the model works, and we do have evidence not only from my institution at Children's Hospital of Philadelphia, but other hospitals in the United States and Thailand, and a manuscript that will be coming out in just about another month from implementation of my model in Japan. So let's talk about informed decision-making. If we think about this young lady who is pictured on this slide, this young lady at the time of the photo was 16 years old, African American, low income, lived in West Philadelphia. Her mother did not breastfeed, her aunties did not breastfeed. She never saw anyone in her community breastfeed. So what would make her think that she should provide milk for her baby? So we know that many people, many families do not initiate breastfeeding due to their culture, a lack of family support, a lack of education, or exposure. So my call to action to you is how are you going to make sure that all of your families are actually making informed feeding decisions related to the use of human milk and breastfeeding? So at Children's Hospital of Philadelphia, we provide personalized one-on-one prenatal assessment and education tailored specifically to the child's diagnosis and to the family's needs, because not all of our families come with prenatal intent to provide milk. We provide them with all of their supplies prior to delivery. We teach them hands-on how to utilize the pump prior to delivery because all of our babies are sick. We involve a partner or support person, and we teach them the science of human milk. So I just want to touch briefly on family because family may be defined in many different ways. Most of us think primarily about breastfeeding from the concept of it is something that the person with XX chromosome can do. So people will use the term the mother. The mother is the person who breastfeeds. And in the heterosexual paradigm, when the male partner is involved, we do have research literature, both from the United States and around the world, that in the heterosexual paradigm, the father is actually the most important and influential person in decisions surrounding human milk and breastfeeding. So that tells us that as healthcare providers, we should be spending our time talking to that male partner, that he is the most important person that we could target interventions to. So in the United States, June is Pride Month. This is the 51st annual celebration. I do want to acknowledge we are going through a very challenging time in America, and we really can't acknowledge this without standing up for those in our community who are impacted by systemic racism. So if we have two men, for example, who are adopting babies, we don't have substantive peer-reviewed literature that says that men can lactate. So should two men be giving information about accessing human milk? What is our job as healthcare providers in helping all families make informed decisions? If we have a person who is a male converting to female, there is limited data that supports that lactation experience. There is one published article about medication and facilitation of transgender women's lactation, and there was a poster presented 2 years ago about inducing lactation in the male who converts to female, and they were able to secrete milk. But there is very little published literature about male to female persons. If we have a female to male person, if the breasts are present, they are able to obviously secrete milk, and in this case, the preferred terminology is chest feeding. And then if we have our same-sex mothers, we have 2 publications now from my PhD student and myself that show that women who are in same-sex relationships receive little evidence-based information from healthcare providers. So I just want to acknowledge that we have to find out first how that mother defines her family or how that person defines their family and ask them their preferences. Again, this is part of the shared decision-making model. We would want to involve the entire family, no matter how that family is designed, to be involved in the process of providing milk. And in fact, we have a job list that we developed for partners or family members to help support the person who has a sick child that's being cared for in our institution. And that's been published in our Pump Early, Pump Often manuscript. We also have a DVD that educates families about the science of human milk, and you can find more about that on our website. So you may ask, does this prenatal intervention work? You do not have this information in your slides because this is confidential information. This is a study that is currently in progress. I was planning to talk about this in March in Portugal, but this is a sample of about 500 women who received personalized consults delivered by a PhD nurse. We have had student interns who worked with us to abstract data and complete the follow-up survey and to manage the survey. We are still in data collection and analysis. Our first attempt to contact the families was by email. We then made a second attempt by phone, and we're now in the third round is by text. And so we are still in the process of texting our non-respondents, and this is done by Twilio through the REDCap database. But at this point of time, we do have a 23% response rate. And for those of you who've ever done survey research, you know that if you can get over a 10% response, you are really in good shape. We do believe our response rate will continue to grow via the text messaging, but as I mentioned, that is still in progress. So I will ask you not to share the data at all that is on the next screen because, again, this is in progress and confidential. But based on our 116 respondents, you can see that our human milk rates are, significantly statistically higher than the U.S. national data, with almost 90% still providing milk at 6 months, and with 2/3 of the families providing milk at 1 year, twice as high as our national data. And in this sample, and please remember, all of these families had critically ill infants, over 40% breastfed for over a year. So families do deserve to learn the science. On Tuesday and Wednesday of this week, I gave some live webinars about the COVID-19 pandemic for our Commonwealth of Pennsylvania. And Pennsylvania Health Department established a program called Keystone 10 to try to improve breastfeeding in birth hospitals across our Commonwealth. And I talked yesterday and on Tuesday about the need to change the prenatal care paradigm so that all families are learning the science. And this quote is a quote from a nurse and an IBCLC who participated in the presentation. And I really just think it's so meaningful because she says, honestly, I've always taught the benefits of breastfeeding, and I just glossed over the science. You inspire me to change this practice. We all have to focus on the science of human milk. Now, as those of you who are human milk researchers know, there are so many amazing components of human milk that we could spend weeks and years talking about these things, and we could easily overwhelm a family. So I would never expect any of us to cover the multitude of ingredients in human milk with every family you meet, but you could focus on certain ingredients and tailor them based on the family's preference and the family's need for information. So when I have conversations with families, it is very much focused on what they know, what they understand, and what they've heard about human milk or breastfeeding. And many families have no idea about how human milk works, and they also may have no idea what formula is made from. So I'm going to go through a little bit of how I share the science with families as a way to replicate this for the families that you work for. More than anything, we want families to understand that human milk is powerful and that while you could be formula fed, and I am living proof of that, and turn out just okay, formula provides nutrition for a baby, and that's what it provides. Human milk is not only nutrition, but it's immunobiological and it's developmental. So when we first think about human milk oligosaccharides, Dr. Lars Bodie, I'm sure many of you know his work on the important role of human milk oligosaccharides. These one-chain sugars are both prebiotic and probiotic, and they are antimicrobial. So again, in this time of a pandemic, when people are thinking about the transmission of disease and virus and COVID, it's really important to focus on how powerful human milk oligosaccharides are. And Dr. Bodie has showed that these one-chain sugars are resistant to intestinal enzymes and the low pH in the intestine, and they actually come out fully intact in both the infant's urine and in the feces. So when we think about how that breastfeeding can reduce gastroenteritis and diarrhea and urinary tract infection, these human milk oligosaccharides are very important due to their antimicrobial nature. The other thing that is so amazing about human milk oligosaccharides is that they are tailored in that individual lactation experience. So each person who is lactating makes a different profile of HMOs, and they document these differences based on gender and where women live or families live. So it's really amazing to think how the person who is lactating is able to tailor their milk to their child. Dr. Bodie received a research funding grant from the Family Larson Rosenquist Foundation to really understand COVID in milk, as well as how human milk could protect infants from COVID. And you can see this quote from Dr. Bodie: "I'm most excited about this line of research as it might once again show the true power of human milk in helping us fight this darn virus." So this is an article that came out during the COVID pandemic. It is not specifically about COVID, but I think the research is so timely because they focused on how human milk protects against viral infections. And what they found was that multiple viruses were more abundant in stool samples from infants who received exclusive formula compared to those who got just partial or full human milk. So again, we can emphasize to families how important human milk is in the protection of viral disease. Now, many of you may have seen the new Lancet commentary that was published in early May, and they report that they detected the COVID in human milk. In this particular research, though, it's important to note that they use PCR testing, and that does not mean that the virus is viable or even intact. So even if there's viral fragments, they would be picked up. So to date, we don't have any evidence to support that there's actually the ability for the virus to do something in human milk. So my next conversation that I like to have with families is about antibodies, secretory IgA, secretory IgG. It's really important for families to understand that every day that they breastfeed or express milk, every day they are making a new daily dose of vaccine for their child. This is irreplaceable and something only the lactating parent can do. And in that research from China, they did find that COVID antibodies were detected in both the mother's serum and her milk. Human milk and colostrum is also a powerful antioxidant. And so just the nature of being born creates oxidative stress to newborn babies. If a newborn baby was further born early or sick, then they experience significantly more oxidative stress. So oxidative stress can affect the baby's lungs and chronic lung disease, protect the baby's eye, and also decrease the risk of necrotizing enterocolitis. And colostrum, in particular, has been shown to be a very powerful antioxidant. However, mature human milk also has superior antioxidant capacity compared to infant formula. So again, most families that you meet will have heard about antioxidants because you hear them advertised on TV and in the media. So comparing them to things like cranberries or blueberries and how they're good for our body, human milk is powerful for their child's body. Lactoferrin is, if you would talk to Dr. Bo Lauderdale, he would argue the most important ingredient in human milk because it is antibacterial, antiviral, antifungal. It can pretty much kill anything. And so lactoferrin is not something that is present in infant formula. And I think one thing that it's really important to remember is that this is something that is best going to help the baby when we are talking about freshly expressed milk. If we freeze or pasteurize the milk, that is going to decrease the potency of lactoferrin. Bo Lauderdale would probably also argue about the importance of osteopotin. Osteopotin is a protein that is primarily not found in cow's milk or infant formula. And the osteopotin has been demonstrated to be able to internalize into the intestinal epithelial cells. So thinking about the ability of the milk to protect and grow the intestinal mucosa. And this is one of the things I worry about with maternal-infant separation. If hospitals are separating mothers from their children and they are not helping them with the effective establishment of lactation, this means we are going to see more infants get exposed potentially to infant formula, which is going to disrupt the microbiota and potentially damage the gut wall. So keeping babies exclusive, the important role of osteopotin in the development of that gut wall. Human milk is also alive. If you look at it under a microscope, it looks like it is having a party. So we have all of our live macrophages, which are the garbage bin cells, our neutrophils, which go to sites of inflammation, and then our lymphocytic cells. And the lymphocytic cells are important for our long-term cell-mediated immunity. So if you think about all the respiratory and GI protection that human milk affords, families are absolutely fascinated to learn about white blood cells. They think it is absolutely amazing, and they have no idea that their milk is alive, whereas infant formula is dead. So the last ingredient I want to focus on is stem cells. And I am a storyteller. For any of you who have heard me speak, you know that I like to tell stories about my families. And so right before the COVID pandemic started, I was doing our mama care at CHOP. This is our group prenatal care, or the centering model. And if you're not familiar with centering pregnancy, it is a midwifery model of care that's associated with better outcomes overall. And we actually have a manuscript that will be published this summer in Breastfeeding Medicine about our lactation outcomes through the centering model. But we're holding mama care, and I get to go to speak about lactation, and we're all in a circle, and the families all are introducing themselves. That's the first thing I have them do. And I had a family who, between the two of them, had 5 children already. And they said very clearly to me, there is nothing that you can do or say that will change our mind. Our other children were all formula fed. They are perfectly healthy and fine. We are not interested in providing milk or breastfeeding our child. And I said, that's fair enough. That's your decision, but today's mama care session is dedicated to talk about human milk and lactation. So I really do hope that you will stay here and listen to this discussion. And so they did. And so we started out by talking about the science. And so I asked the families in group prenatal care, have any of you heard of stem cells? And one of the fathers raised his hand, and he very articulately talked about stem cells and how amazing they were because they have the ability to develop into different types of tissues. And so I said, you are so right. You are spot on with your definition. And I said, researchers from the University of Western Australia have identified that infants consume tens of thousands of stem cells during the feeding of human milk or breastfeeding. And in fact, they've demonstrated their impact on the infant's brain. And we do know that infants who receive human milk or are breastfed have more white matter in their brain, they have more gray matter, they have bigger brains overall. And this family who said, there's absolutely nothing you can tell me that will change our mind, as soon as we were talking about stem cells, both of them began to sit up in their chairs. They began to lean forward. You could see that there was a total click or light switch in their brain that said, wait, we don't want to give our baby formula. We want to provide milk. And so after the mama care session was over, this couple came up and talked to me, and they were actually a little upset in that they said to me, we have 5 children amongst the 2 of us. We never heard any of this information you talked about today when we had our other children. Why? Why? And I think that's a really important question we have to ask ourselves. Are we giving all families equal opportunity to make informed feeding decisions? We need to use the science. Especially in this time of the pandemic, even if the virus might be in the milk, we don't know how likely it could be transmitted. Based on the low number of cases so far, it is quite low, and infants who have contracted COVID have had generally mild symptoms. So this World Health Organization states, weighing the multiple benefits of breastfeeding against a small potential risk of COVID infection, we are fairly confident that the benefits far outweigh the risks. So if for some reason we did not have human milk available from the lactating parent, then pasteurized donor human milk would be a better choice than infant formula. Globally, still not all hospitals use donor milk. In the U.S., the rates are only about 50% of hospitals. We have a very liberal policy on the use of donor milk at Children's Hospital of Philadelphia, including parental preference. So if the parents were unable to produce a sufficient quantity of milk, we can support them with the use of PDHM. And if you think about the cost of pasteurized donor human milk compared to, for example, TPN, the cost is significantly lower. In the U.S., our milk banks are governed by the Human Milk Banking Association of North America. They do have some nice information on their website about COVID. We do know that studies have shown that by heat treatment you can destroy similar viruses. And so we do know that pasteurized donor human milk is very safe. We are seeking donors. I'm sure all over the world, milk banks are seeking donors. There is a deferral period for COVID-positive families. We have not yet at our hospital screened a COVID-positive mother for the milk bank. Now, lastly, with the frequently asked question sheet from the WHO, they do talk about wet nursing, which also could be considered informal milk sharing. And in some communities, informal milk sharing is preferred over PDHM. And this is a study that was just published in May, where we worked with the Orthodox Jewish family community in America, and they really quite articulately discussed the importance of informal milk sharing when other families have sick children. Again, going back to the UK guidance, where they talked about now is not the time to stop breastfeeding, we have very few publications around the world about breastfeeding beyond a year or about tandem breastfeeding. But I think based on the science of human milk, this is not the time for a family to consider stopping breastfeeding. I'll end with sharing this story about the power of human milk. This baby had a congenital anomaly called an omphalocele. The baby was prenatally diagnosed with that. The mother was pump dependent for over 2.5 months. The baby required 8 surgeries. The middle picture is her direct breastfeeding, and the last picture is her at 1 year. The mother provided 100% human milk diet for the first year and had so much extra milk, making over 1 liter of milk a day, she was able to be a donor to the milk bank. So fast forward to the present, the baby in that picture is now just turned 10 years old. She is in perfect health. She has absolutely no developmental disabilities, delays. She's actually brilliant. And her mother, based on the experience that she had with her daughter, now has become the executive director of the Human Milk Banking Association of North America. And both Charlotte and Lindsay allow me to share their story. It shows you the power of human milk and breastfeeding as life-saving medical intervention, and it shows you the power of transforming families' lives through human milk and breastfeeding. We are certainly in a challenging time, but the one thing we can do is to continue to promote, protect, and support evidence-based lactation care. These are just some quotes from our case series manuscript that is under review. It really does show that we must do better. Janice talked about that she didn't feel prepared. Stella talked about that she did not have adequate help and that she felt lost and going online and asking friends. And Ruth echoed these concerns, saying that she did not have access to in-person lactation consultant help. So I think I've ended with just maybe 1 or 2 minutes for questions. I certainly thank you for your time, and I will present again on July 9th for Medela.
Thank you, Diane, for that wonderful information. It's always great to hear information from you. We are at 10:30. I don't see any questions coming in. I did want to let everyone know that we do have some additional webinars coming up, one on June 25th. The next one, Diane, that you were speaking of on July 9th, registration will be available later today. I'm working on getting that up on our website, medelaeducation.com. We have a webinar on July 15th and one on August 19th. For more information about those and to register, you can visit medelaeducation.com. And again, for those U.S. Attendees, your certificates should be available on Monday for this. Once again, Diane, thank you for your information, and thank you everyone for joining us today.
Thank you so much.